Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me from out of state. This is a patient with a dislocated single-piece acrylic lens in the capsular bag. And so you're going to see how I'm going to take on this case, my preparation and planning and my strategies. Really, a lot of these cases really depends upon having a plan A, B, C, D, and knowing what to do when things go sideways. And so you're going to see just my thought process. I'm going to go ahead and do the best I can for this patient with what's in front of me. So this case just illustrates the point that preparation is the ultimate key to success with regard to surgical decision making. And so remember, if you're under duress or you're doing surgery, it's hard to think clearly and making decisions quick on your feet. And sometimes those decisions end up not being the right decisions. But if you think ahead and you've gone through these scenarios before, you can be better equipped handling these challenging cases. So you can see this is a single piece acrylic lens. It's in the capsular bag. You can see the anterior capsulotomy is intact. I'm turning the eye. This looks like the right eye, and I'm sitting supratemporal to the patient. And then we're going to go ahead and make my corneal mark. So I'm always prepared for doing a Yamane technique in case I have to. So I use the end of a cannula with ink, and I just press the ink on the limbus and then do the same thing on the other side, 180 degrees apart, using the cannula to find that bisected plane. And then this is the fixed caliper 2.5 and 2.0 millimeter caliper from Epsilon. And I'm going to indent in radial fashion, 2.5 millimeters and then 2 millimeters adjacent. And then I quickly do the same thing on the other side. And I do that because as I do it quickly, the little indentation, the dimple through the sclera, is still visible on both sides. So this is the quickest way to do this. So go ahead and indent on both sides. And then mark 2.5 millimeters and 2 millimeters adjacent, and 2.5 millimeters posterior here in radial fashion, and then 2 millimeters adjacent. So now I'm ready to go if I have to employ intrascleral haptic fixation technique. And so now I'm making my incisions, first on the right side and then the left side, and these are my paracentesis incisions to explant the lens. This is intracameral epinephrine, and as I'm injecting it, I'm checking for vitreous. I'm checking the pupil, make sure it's stable, but I'm also checking for vitreous to see if there's any, and I do not see any vitreous with that irrigation of epinephrine. And now this is dispersive viscoelastic to fill the anterior chamber, coat the cornea, and also to push back any potential vitreous that might be there, but again, there wasn't. And this is a 3 millimeter keratome blade. Make my incision. Again, I'm always perpendicular to those marks. And using a two-handed technique, I'm going to go ahead and very gently lift that three-piece lens up out of the bag with, again, two microforceps. I grab, and very gently, I'm tucking that trailing haptic and then lifting it up over the anterior capsule and the iris, and then gently grabbing and re-grabbing little by little. I'm going to the other side, grasping the leading haptic, tucking it and pulling it up into the anterior chamber. Once you have both haptics up, you know that the lens is secure. And then I'm going to go ahead with micro scissors to cut it. I always like to cut a little bit sideways as I do this. It helps me visualize what's going on. And of course, I'm very careful not to nick the anterior capsule when I do this. Cut all the way through, and then switching back to microforceps, I'm going to stick with the left side since I'm holding it anyways, and very gently going to grab that trailing haptic, very gently grabbing and re-grabbing, and then pulling the tip out. And once I have the tip pulled out, I can just re-grab the edge of the optic. Always protect the corneal endothelium with the other forceps when you pull this out. So I always do that. That's my standard technique. Because there's a lot of techniques out there where you can get creative in pulling lens pieces up. But that's the one thing I get worried about. You don't want to ding the corneal endothelium as you do it. So I'm grabbing the edge of the optic, and as I pull it out, again, I'm shielding the corneal endothelium with the other forceps. And so now the lens is out. And here I'm going to check the capsule. Let's look at the capsular bag. Let's look at the zonules, and let's see if there's any integrity to them. If there's no integrity, then we're going to do the Yamane technique. So I'm retracting the pupil with a Lester, and I can see that the capsulotomy is intact. but I'm also seeing that the posterior capsule is not intact. You can see there's large tears there, but again, the anterior capsule is really nice and intact. So again, look, I'm pulling. And it's interesting because I have a feeling this lens dislocated, and it's important to kind of get an idea, like a detective at a crime scene, trying to figure out the story of what happened. And so, if there's actual poor zonules, then that's a totally different scenario. But as I look, I can see there's radialization tears in the posterior capsule here. And so I suspect is patient had anterior capsulotomy that was intact, and then during the primary cataract surgery maybe had a posterior capsule tear, but then they were able to put the single piece acrylic lens in the bag, and it was stable for a while, but of course as the vitreous liquefies, then the lens begins to collapse. And so I have a feeling that that's the scenario here, and as a result I feel like I can still use the anterior capsule, and I feel there's enough anterior capsule integrity to put the lens into the sulcus with optic capture. So that's my plan. I'm going to go ahead and place the cartridge. I already pushed some viscoelastic into the cartridge here, and then I place the lens into the cartridge, making sure it's seated deep, making sure the leading haptic is coming out through the barrel, trailing haptic coming out from the back. I bring the wings together, make sure the optic is going to bend concavely, and once it's bent, I go ahead and slide it into the injector. As I push it in, again, I use this same lens for my Yamane techniques. I'm very comfortable loading the lenses myself, and I have a lot of confidence that I know what I'm doing with this. Go ahead and make sure that trailing haptic's up, out of the barrel. Go ahead and advance the plunger, and as I advance the plunger, I can see the lens is coming out and it looks intact, so I'm ready to go. So again, I push some cohesive viscoelastic to fill the sulcus here, and as I do this, I am assessing the capsular bag. So again, some cases when the capsular bag and the zonules are really unstable, you can see the capsule just kind of is flimsy and it's collapsing. I do not feel that in this case. You can see that this patient has reduced scleral rigidity as I'm trying to place the injector into the incision. Go ahead and advance the leading haptic going into the ciliary sulcus, making sure the optic comes out flat. I'm rotate my hand with the barrel, making sure the optic comes out flat, and then disengage the injector from the trailing haptic, making sure it's pointed to the right, and then carefully dialing the trailing haptic into the ciliary sulcus. So again, both haptics are in the ciliary sulcus now, recentering the optic. What I'm going to do here is basically tuck each optic edge under the rhexis. And so again, this is a fairly tight rhexis, so I get a pretty good cat-eye configuration. At this point, I'm going to go in with the INA, but first I'm going to bring the irrigation infusion pressure down from about 40-something to 20. So I go in with low infusion pressure. I don't want to cause a huge pressure load and hydrate vitreous or whatever. So, and I certainly don't want to invite vitreous to come forward. And so again, I have good optic capture. It should not cause anything to come forward. That buttonhole configuration with the lens over the capsulotomy should make it a nice stable situation. Again, under low infusion pressure, I'm starting to remove the viscoelastic from the anterior chamber. You can see the lens is well centered. It's not moving around. Again, indicating that there's good zonular integrity in this case. Again, a lot of cases when you start to remove viscoelastic, if you have unstable zonules, you'll see the lens just kind of wobbling around as you remove viscoelastic. Again, none of that is going on in this case. So again, I am throughout the entire case thinking to myself, is this going to be stable? Is this going to be stable? And I'm trying to convince myself, I'm trying to prove to myself that this capsular bag in this situation with the lens is going to be stable. And if it's not, of course, then I'm going to switch and do a different technique. So I switch here, go to the visco mode. You can see again, even though with higher infusion pressure, nothing's happening. There's no dislocation of the lens. It's nice and centered. And so I feel a lot better about this situation. And again, I've been able to bypass and avoid a much bigger surgery with vitrectomy, surgical PI, scleral fixation with the needles, and so forth. So I go ahead and quickly transition, hydrate the incisions. Again, throughout the entire case, I'm paying attention to the stability of the zonules and the lens. After I hydrate the incisions, I go ahead and place a tendonylon suture. I always do that in these kind of cases. And then I bury the knot. And again, I'm just finishing up hydrating the incisions. And that's the end of the case. So again, this patient came from out of state. It's always a challenge to coordinate these cases because these patients are coming from far away. And when they come in, you really kind of have to stop and do a whole bunch of tests because you want to avoid them from having to come back and forth to see you. And we went ahead and did the surgery. I was able to see the patient early post-op day 1 the next day in between cases because he needed to drive back home. And the patient had 20/30 vision uncorrected. Of course, still had a dilated pupil. In these cases, I always put a drop of atropine at the end of the case. With these cases, I want to make sure on day 1 I can see everything clearly. I want to make sure that the lens is stable and in proper position at day 1. I also want to check the retina. So I always look at the retina on day 1, make sure everything looks great. So again, with a dilated pupil, this patient had 20/30 uncorrected vision. He was very happy with his vision. Of course, he was like, it's still a little blurry. And his vision being 20/30 uncorrected in the context of a dilated pupil was rather reassuring. I encouraged him that after the dilation wears off, his vision should get even better. And this patient was rather happy and relieved that we're able to bypass a bigger surgery with a 15-minute IOL exchange, placing a sulcus lens with optic capture. So I hope this was helpful to you, and I thank you for your attention.